So thank you so much for joining us to this first webinar on Celiac Disease Awareness Month. We are delighted to have you. So happy Celiac Disease Awareness Month. As you know, it is almost become a tradition that AOECS organizes a series of webinars. And today we begin with the first one on transitional care and follow-up after diagnosis deficiencies and opportunities. Our idea is to have quite informal dialogue with the three speakers. We're still waiting for one of the speakers, but we hope he will manage to join on time. We count with around 45 minutes discussion with them, and then we will open the floor for Q&As from your side. We thank our sponsors, Takeda and Dr. Falk. Without them, we wouldn't be able to organize these webinars. And without further delay, I want to say hi to, by the way, my distinguished speakers have allowed me to treat them by their name directly because I told them I will be incapable to pronounce their family name, but they will do it themselves. Welcome, Marianne from Georgia. Good to see you, and thank you for having accepted this invitation. And also, Jana, thank you.
Thank you for inviting us.
Maybe first of all, Marianne, will you give like a few words of introduction on who you are and what is your link with celiac disease transitional care and also your country?
Hello once more to everyone, and many thanks from my side to Veronica and also all organization who implemented such kind of meeting, which is very essential, very important, not only for doctors, but also for parents with celiac children and also the patients with celiac disease. I'm from Georgia, Mariam Gugunishvili, and yes, you're right, to pronounce my surname is not easy. I'm pediatric gastroenterologist, and I do see children with GI problems and also with celiac up to 17 years of age. And in Georgia, the prevalence of celiac disease is unfortunately not known yet, but we do estimate, as usual, as in every country, is more or less 1% of population.
Thank you, Marian, so much. What about you, Jana? What is your, well, you are a member of the Celiac Youth of AOECS. What is your background?
So, hello, my name is Jana Chernohorsky, and I'm from Croatia, but currently studying in Ireland. And yes, I've been diagnosed with celiac when I was 5, and I've recently turned 19, so I have had the pleasure and the trouble of transitioning from the child care to adult care for celiac disease after being with the same doctor for 13 years. And yes, I'm very delighted to be in this webinar and to talk about this because I think it is a very running issue that it affects so many people, so many celiacs, and I hope the discussion will be productive in that sense.
Wonderful. Thank you so much for taking the invitation. So I guess the first question for both of you, maybe I give the floor first to the doctor and then to the patient.
Mm-hmm.
So in your view or in your journey, what are the main deficiencies you have identified in the celiac's transitional care, but also maybe in the follow-up after diagnosis?
Yes, it's very important question, and but not easy to answer. I mean, from perspective of view of doctor, I would say that the transitional time is real lacks standardization. So the major deficiencies are absences in structured plans, which actually should be done by doctors. And unfortunately, as I said, I'm pediatrician, we sometimes discharge our patients from pediatric services without a clear handouts or clear continuity plan, which they would use with the doctors, with general practitioners or adult gastroenterologists. And of course, they are clinically stable. I mean, if the adherence to diet is good in time period of pediatric time period, then of course they are clinically stable. And they don't think much that it can be worsened if they will not do the diet strictly also in adolescence and in adulthood. So I think the main problem is that they have to have some plans and they have to know how to manage disease themselves and how to let the doctors to manage also from their side this disease.
Very good.
Yeah.
Jana,
What you would add?
I remember I was very young when I was first diagnosed, but I remained with the same doctor after my diagnosis on yearly checks, and that was all fine and that was all structured. But then the problem arose that I was with the same doctor for 13 years, one doctor that knows all my issues, celiac connected, because as we know, celiac often comes with some side problems. And then I turned 18, and there was the big question of what now. And as Mariam said, there's no plan, there's no structure. And being a young person, first time entering healthcare, I was walking without any direction. I continued to be with the same doctor for a year after I turned 18, although it was illegal and I shouldn't have done that. But that is the main problem. There was really nowhere I could go. There was really no directions, no directives for patients for where to continue their care.
and were you traveling? Were in your same country, or you were already traveling abroad when you transitioned?
I was traveling abroad shortly after my transition, but I continued my care here in Croatia. But it is also a point to make as well. If I ever had, thank God I didn't have any issues with celiacs and contamination when I was in Ireland. But if I had, there would be nowhere that I could go to get examined to continue my care in Ireland. So I was also obliged to stay in Croatia to just to stay and continue my care here in Croatia.
I would answer first, yeah? Or the gap which you mentioned leads to two things. I mean, clinical problems and psychological problems. And one of them we heard from Jana. Clinical problems, I mean, this gap when they are confused, patients are confused, they don't know what they have to do. They can go to anemia, osteopenia, osteoporosis, growth problems, or some associated autoimmune other diseases can be misdiagnosed or overlooked in this time period, in this gap. And also the psychological problem is very high. As a children, you always get support. I mean, support from parent and support from doctor and support from psychological point of view. But when you're adult, we don't think as much on psychological aspects. But in this age, as Jana mentioned, 18, 19, 20s, we get more pressure from our peers. They do go out more, so they do have more contact with gluten, and also they want to be the same as the others are. And they want to do the same things what the others are doing, and it's normal. It's normal. So they have to be psychologically very much prepared to this age. That's why this gap leads to this kind of missed problems, and psychological support should be one of the first support which they do have to get. The rest, clinical support, time by time they will get. It is not as much more problem, but the rest is very important.
It's nice that you mentioned about psychological issues and support, because we will have our third webinar precisely about that. So it's very good that you pointed it out already. Jana, will you agree? What is your impression from your side?
Yeah, absolutely agree. As Mariam pointed out, literally from one day I've been considered a child, and the other I'm supposed to be adult and take care of myself completely. So I think the main missed opportunity here is getting the transition to be gradual, not from one day to another, not from just one program to another that I'm completely supposed to switch in the matter of days or months. Maybe start early, maybe at the age of 17, start preparing the child and the parent to search, to seek care in the adult departments, to gradually become acquainted to that doctor that we're not as strange when I first have to meet him at the age of 18. So maybe making this transition longer, making it more gradual, keeping the contact maybe with the child doctor even at the age of 19 to just smooth out some differences in care. I think that is the best approach to the whole transition.
Very good advice. I guess we could go into that direction. Sorry, and before we continue, there are some people in the chat saying that the sound is not good, that they hear you a little bit too low, Marianne. I don't know if you have the possibility to get closer to the micro.
Okay, I will
Right.
try.
We apologize for that. It's our first time using the software, so let's see if it gets improved. Yeah. So it is interesting because you share very much of the same points, and yet you are from the different countries. So I wonder if you already see like benefits of setting up very standardized protocols that could help transitional in a gradual way, as you said, Jana, transition in the celiac disease from pediatric to adult care. Do you see a value? Do you see a benefit in setting up standardized protocols that could work, let's say, for all European countries and maybe beyond?
Sure, and it must be standardized protocol, which means from the, if I would speak in name of Georgia, we are trying to do so-called program, which will include all children patients, and we should know and we must know the real amount of the patients. Why do we need the real amount? I mean, the whole amount of the patients, because they must not be lost in adulthood. Some patients don't think that this is disease which must be mentioned afterwards, and they just they are lost, and the adult gastroenterologists also don't have any information really how many patients we do have in childhood. So this must be structured. All patients must be somehow gathered in one program, in one database, so they will get enough attention also from the doctors. So I mean, these programs they will call also the patients, and they will ask, you are diagnosed with celiac disease, how are you doing, what is your problem, do you need our help? So it will be very important. The second, I would totally agree with Jana. This transitional time, it must not be 1 day transitional time. And it's for other diseases, is very, very familiar. The doctors are familiar with so-called joint pediatric adult clinic sessions to foster continuity. I mean, they do start at age of 13, at age of 14, it depends country by country, and they do share the patients, and they do see the patients together, pediatrician and adult GI doctor. They do see patients together, and they do they are making plans together for the future. And also in 21st century, everything is more or less digital, and that's why digital health tools would help also the patients, like some kind of applications or some kind of telemedicine, which will promote the engagement of the patients and the doctors also together. So it must be like patients must have their own information, but they must share this information also. This will be more helpful for both sides, I would say. And the protocol would assess what is necessary, how often they do have to do tests, they do have to do controls, monitoring of the celiac disease, how often they have to visit multidisciplinary care. I mean, celiac disease is not just disease of GI system. So they have to visit other endocrinologists, hematologists, also rheumatologists. I mean, this is disease which must be managed multidisciplinary. So this must be really written like protocols, what we have to do with these adult patients.
Excellent points, all of them, really. Thank you so much, because I think you're right. Traditionally, celiac disease has been associated to gastrointestinal disorder only, and maybe that also partially explains that there is lack of awareness among other health professionals. But the point you are making on trying to have a multidisciplinary approach and also gradual and also digital is very exciting. Very nice what you just suggest. What about you, Jana? It's
Well, I think as a patient, I would definitely benefit from a standardized protocol, especially now that I'm moving to Ireland. would be very nice if the same protocol would apply to both countries, that I don't have to think twice about learning both systems and how both function, but to have some kind of structure that is applicable to all European countries. Obviously, from some kind of practical point of view, the protocol would probably take the form more of a guidelines before, because obviously the healthcare systems in each country are very different. The approach the doctors take is very different. For example, in Croatia, I'm monitoring celiac not through the GI but through my gastroenterologist. So those some kind of small differences that one unique protocol would not encompass, but definitely some kind of structure and guideline that is applicable to all countries would benefit the students and all.
Yeah. Very, very good. Yes, I just realized that our third speaker has had some issues probably to join, but we continued with you this very interesting dialogue. And you already touched upon that, now all the difficulties, how realistic it is to have a unique protocol across countries, and if it's something that we could say, okay, we know that is maybe an ultimate aim, but we are not yet there. So let's start with a small baby steps towards a unique protocol. And how will they look like, those baby steps towards unique protocol? Jana and Marian, in your view, what will be like the first maybe small step that we could do as AOECS or the national celiac societies that belong to us? If you were to suggest a first step, what will that be?
Nothing is impossible. I would start with this, that nothing is impossible. Everything is done if we want and if we just sit and speak and discuss. Of course, baby steps are important. We cannot start with huge steps, and association also, and community. Actually, the reason and the aim for associations and organizations like to be like advocacy groups, which would advocate for lifelong care pathway. We have to advocate that this is not something for 1 year, for 10 years. This is whole life pathway and a long run period. And celiac disease is not just diagnosis and diet initiation. This is not the way how we care about the patients. That's why must be, first of all, I would say that registries are very important, national registries. And then when the whole world knows the registry, the problems, then the help will be more beneficial. Of course, rising public awareness is very important because still the number of diagnosis, the number of cases which are diagnosed is not enough. Many patients are not diagnosed easily. That's why when the person knows the clinical manifestation and the problems, they do go more often to doctor. So the information about celiac must be very much provided everywhere, in schools and in all institutions. And also the training between the countries would be very important, because in some countries like Italy, the experience is much higher than in other countries. So I would say that this first step would be sharing the knowledge among doctors also. When we share our experience, then the other experience is coming. So I would say the first step would be sharing the experience and planning the mutual trials, mutual parts of how do we summarize the problem and how do we make the plans of solving this problem.
Wow, you have given a lot of food for thoughts, Marianne. Jana, what will be your points here on the possible?
Well, I agree with Mariam. I think she pointed out a very good point, which is like using communication between doctors, but I would also say between patients who have gone through this transitional care. And I think this is a very concrete thing that associations can do very easily, is just setting up a platform for people who have gone through it recently to get their point of view, get their pointers and their advices, to just like give opportunity to those who are transitioning now to talk to the veterans and get their tips and tricks. But of course, ultimately, I think that the aim is to have a guidebook, guideline. Maybe it can start with something very simple, very, very vague, but just like a small point by point guideline just to order our thoughts, just to give us some kind of direction. And maybe that over time, ideally, that guidebook would become more detailed and more structured, but just to give the patient some kind of general direction to go in which they should go to.
Fantastic. Yeah. You almost answered my other question about the opportunities that you think celiac communities should take from this instead of being sad about the issues, be more proactive. You mentioned a lot, but maybe you have other ideas on what other opportunities we have or the opportunities that come from this program, if you wish.
You mean what association could do? Yeah.
What associations, but maybe even communities without being associated.
Yeah.
I leave it up to you, both of them.
Yeah, I would say communities are there to make, for example, the importance in small countries like from where I'm coming, from Georgia. Yeah, the labeling is very important. Sometimes the patients do not know what they have to eat. So first most important thing is labeling, and we have to.
Hi, Alfonso. Yeah, go ahead. Continue. He will
Okay,
take.
I will continue then. Communities would, I would say to communities to advocate what is really important for patients. So labeling, they should know what they're eating. The second, they must know that all institutions like restaurants, cafes, kindergartens, schools must be provided with gluten-free food and gluten-free environment, because it's not only we don't have celiac just at home, we do have everywhere. So also the community must advocate for the healthy environment outside. And then third, I would say that communities must advocate also for financing the research about celiac disease, like medicine or other diagnostic methods or anything regarding to research about celiac disease.
Thank you, Marian. It just occurred to me because you mentioned something before about other diseases that are doing transition different. Are there lessons that we could already learn from other patients' organization or other disease, other ways that come to your mind?
Sure, mostly oncological diseases.
Oncological disease.
Of course, we have and we must to learn from other fields also. Of course, mostly oncological patients do have really good transitional care, and we could get many help from
that. Thank you. Jana, your turn.
Yes, I would say that's primary kind of goal and aim of association is to connection, being with patient, and what I mentioned of like connecting patients and their previous experience with transitional care, being doctors with doctors, as Mariam mentioned, connecting the pediatricians with the adult care GI, but also patients and doctors, getting them all together. So I think that is the main thing that associations should aim for, connecting both sides, connecting all of these different elements that have to come together for a successful transitional care. But also being as association, I think now it occurred to me how Maria mentioned that oncologists have a good transitional care. Maybe connecting with the other side, with the oncologist-based associations, getting their points of view, getting their pointers and experience. So I think that they are the ultimate advocates for the celiac patients, and they should act in that direction to join all sides together in one complete packet for transitional care.
Thank you. I also like it what you mentioned before, Jana, about this communication places where the veterans could talk with the newcomers and so on. I like it, that concept. And I also thought of, more and more in Europe, there are plenty of Erasmus students going from their countries to other countries, and they could also share both the challenges, but also what they have learned in other countries, how and the protocols look like, and so on. I don't know if you will agree, because you are precisely one of these. Yeah. So, no, fantastic. I think we lost Alfonso, unfortunately, due to technical issues. Let's see if he's able to connect again. But so if you were, your advocacy pitch to the policymakers in your country, what will you tell them? Do we change order or we go with you, Marian?
Okay, no problem, for sure. The message for policymakers, I would say that the celiac disease is lifelong disease. So patient is at any age patient. And this, we have to prioritize lifelong care pathway, first of all. And this includes funding for regular follow-ups, funding for dietetic services, funding for psychological support, and research. Of course, from point of doctor, I would more prioritize research. And of course, implementing structured transitional models. We have to advocate our own policy to our own national policymakers for national registries, which will lead cost savings for the future complication of celiac disease. It is also very important for them. They have to save money. They have to give money for saving money. So that's why early diagnose, good management, and good follow-up will make much cost savings. And of course, we have to recognize that good care does not end at diagnosis, and it begins there at that time. So support policies that enforce continuity, stability, and quality in celiac care is very important.
Thank you so much. Very, very good, direct and clear. You mentioned it before, and I think it's worth highlighting it. Celiac disease is much more than just diagnosis and diet.
Sure.
So I think that is like the bottom line that we want to also emphasize here. Jana, what will be your policymaker speech?
Well, something that seems very obvious, but I think is overlooked is considering both the positions of patient and doctor. I feel like often when policies are made, they're considering either the position of making the transition easiest for the patient or making it easiest for the doctor. And it's always that one side suffers through the whole transition. So it would be easiest for the patient to just go from one doctor to the other, get the documents in, but then we get the doctor's point of view that they're overworked, that all of a sudden they have a whole new patient with a very, very thick medical file, and they have to catch up on all their problems, and they have to take care of everything, because as we mentioned, celiac is not always just about gastroenterologist's part of the care. It has a whole range of issues that not only one doctor can take care of. So getting complete care, not just one or specific aspect of celiac, but getting the whole picture of the patient and not taking it all on one doctor, but to get this kind of network of doctors that can work efficiently for the patient's care. That I think that would be best solution.
Brilliant. Okay, so I think we have time for questions from the audience. I would suggest that they share their questions. I should have invited them first, but share your questions through the chat. And also, maybe you can just log in to speak loud. To be honest, we are learning on using this chat, and I still don't know if you can just raise your hand and take the micro. But if you can use the chat, the live stream chat, please do so and ask your questions to Marian and Jana. That is a wonderful opportunity. It's not always that we have these two wonderful speakers available, so please do so. Yes, and I think I can confirm, just received the email from Alfonso saying that he had technical issues. Well, these are technical issues, right? Okay, so there is a question here. Hello, what is the best practice? How to support adult newly diagnosed celiac? Marian, what will be, in your view, the best way to support them?
Of course, as I mentioned, to be honest, to be celiac in childhood is much easier to be diagnosed with celiac in adulthood, because when you whole life are eating normally and at one day you understand that no, all your nutrition and all your diet now is changed, it is very big issue sometimes. So I would say at the beginning, very close contact with your doctor, and all kind of investigations for other autoimmune diseases and other deficiencies, and also very close contact and very huge help we need from psychologists also. And when we do have the both help, psychological help and the clinical practical help, then everything is manageable. So I would suggest both help from the beginning on.
Yeah, but the question is also related, and I can give it also the floor to Jana, because it's also mentioning, okay, it seems like the diagnosis is quite a standard to get diagnosed, and also if you search for celiac on internet, you get information. But we know that sometimes Dr. Google is not working quite right. So any comments from Jana and you, Marian, about how to really go? What will be the...
Don't Google your diagnose. Don't never Google. Better to ask real doctor, of course, because of course many scenarios you can read in Google. Easy scenarios, bad scenarios, the worst scenarios. So this disease is something that the symptoms and clinical manifestation, clinical problems are not same for all of celiac children and celiac adults. So never Google the diagnose, and better to go to doctor and ask for help and ask for advice. I would say so. What you
Thank
would
you.
answer?
What
Yeah.
about you, Jana?
Yeah.
Do you think young generations have the tendency to go more to Google Doctor?
Yeah, I think that Google is it's an always a source of information. But I think this is one thing that celiac associations have worked really hard on, and maybe by now really succeeded, because I see more and more people who go to celiac associations to ask questions sooner than Google. I think that's a big accomplishment that we made over the years. I think celiac associations have big responsibility to share reliable information. I think they're doing a very good job on it so far. Of course, it can always be improved, and we can always reach more people, but I think we're going to the right direction with that.
Wonderful. A very good point, because there is a lot of effort and caring and responsibility behind that. So absolutely, if you have questions, go to the Celiac Society of your region or your country, and you will get reliable information and not something that you don't know. Yeah, so there are two questions. One is about if you keep the correct diet and your stomach is still in pain, what should we do? And the other also related to diet, besides following a diet when you have celiac disease, what are other important steps you should do to protect your health?
Of course, if you're on strict gluten-free diet, but still abdominal pain is ongoing, we have to check for other diseases, because abdominal pain is not only because of celiac disease. So we have to search other diseases. This first question. And the second question, what we have to do for general health. Am I right?
Yeah, besides the diet.
Yeah, at the beginning, of course, the patients are lacking many things, macro and micronutrients. So we have to check if we have some kind of deficiencies, vitamin deficiencies, and our health, bone health, we have to check. And then with treatment and with normal balanced nutrition, the health will be normal. And the rest is regular recommendations. And as we others also without celiac disease, we have to do our we have to be active, the normal physical activity, balanced diet, and the rest, which is generally normal, good habits, life habits.
Do you have any additional advice, Jana?
I think I shouldn't really speak instead of a doctor. That's also one good point to make. Don't ask
No, you
the
don't have
patients about this kind of thing.
experience. So
But yeah.
If you want to share some of your experience, Dr. Marian, you mentioned creation of registry of children patient. How do you see this can be done? How can national associations contribute to this? And in general, other challenges that you mentioned?
about register, of course, association is having more information rather than one doctor in the country. So association should promote to have as much members as possible. Much member in association means much information about the real amount of patients. And of course, association should have in the all regions of the country someone who will gather the information. For example, not only in the capital, we have to gather the number of patients, but also outside, all over the country. So in all regions should be someone responsible person who will gather the information. How many patients do we have in this region, in this particular region? And association would help and would help not only doctor but also the government to know how much patients do we have. It is not easy work, so association, this needs money. It's not easy to collect information. Everything in this world needs money, so association needs money, financing for that, to go everywhere and to catch each case. And for the rest, I would say the goal of association should be raising the public awareness. I would say the goal, aim should be this: speaking
maybe even
speaking for patients and patient needs.
Yeah, and with that awareness raising, probably fighting all the misperceptions there are around celiac disease would remind me also some of the questions I saw, because there is, and is the next webinar we will have next week. There is another question. I think I begin to wrap up because I see the time. From Greece, actually, I think. What about gluten-free products? Here in Greece, all products are really expensive. It will be nice for all countries to have price protocol, etc. Also, what about markets? They should be more informed and responsible about where they, unfortunately, we cannot regulate the market prices. It's beyond our that, and I think indeed there is a regular trend that gluten-free products, also because of the production model, is more expensive than regular.
Everywhere a gluten-free product is expensive.
Yeah, it's not only because of the margins, it's also because of the production. It is more expensive. Okay, there is this question. I just found out that I have dermatitis herpetiformis, and the doctor says that apart from ointments, there is nothing else I can do. On that, I'll have prickles on my skin for the rest of my life, which are very annoying and itching, unbearable. I wonder, after a year and a half on a gluten-free diet, why did it disappear? Okay, so the dermatitis appear after he removed gluten, and also do the symptoms show up whenever I eat gluten without realizing it? It is true that it will never go away. So many questions.
As far as I understood the question, dermatitis herpetiformis came after diagnosis, of celiac disease.
I have also that impression. Maybe we can ask for clarification.
If the patient is strictly on gluten-free diet, herpetiformis dermatitis must not show up. And if accidentally the diet is not strict, then it can, of course, whenever we eat gluten, it can cause problems, GI, skin, any kind of problem, unfortunately. If this diagnosis is correct. If not, there are skin biopsies, and the other skin problems could be also not only herpetiformis dermatitis. So it must be assessed by dermatologists, I would suggest.
Great feedback. National registry is a first important step. Also, civil society acknowledgement that celiac is a serious disease and not misinterpret this as a win. Due to social media trends, eating gluten-free is usually seen as an option, and that it's not taken seriously, even in respectable places. Fully agree, and I think that is what we all aim at, showing that celiac disease is a serious disease. It's not something that is an optional choice, a diet choice. And fully in agreement. I don't know, Jana, what will be since I kept you silent for a while.
No, absolutely agree. And being a young person, I am always being asked how come you're eating gluten free, or is it just a trend? Or, of course, when I do explain that it's a celiac, even then, the whole concept of contamination, cross contamination, is not taken seriously, not by my peers, not but more importantly, not in the public places. That is something that again associations continuously work on, raising the awareness that this is not just some kind of trend, or this is not just something that I imagined. Because I have been told once by my biology teacher when I said I have celiac that he solemnly believes that is just in my imagination, that it's not a real disease. So yeah, just clearing some of those presupposed ideas is something that we should work on all together as associations.
Thank you, Jana. There is another question, Victoria. Hello, what are the exact medical fields we need to consider? Is there anything else besides gastroenterology, psychology, and nutrition? Yes, there are. Huh? Maria, maybe you
Sure.
can give here.
It changes patient by patient what they do need, which field, which other fields, but generally hematologists, dermatologists, as we understood from the recent question, endocrinologists should see this patient if there is a need. I will not say that this is essential for each patient, but it depends what was the first clinical manifestations, how the diagnosis was made, what was the problem. Of course, GI is first, and mostly the patients do have GI problems, but celiac disease could be diagnosed just because of chronic iron deficiency anemia, or just having diabetes type 1, and then should be excluded celiac disease. So it cannot be generalized. It sometimes depends on the patient's history.
Thanks. Yeah, there is another comment. Yeah, that of course the difference between countries is tremendous, and in Czech Republic they have a good supportive organization, but there are other places where indeed people can get lost as a new diagnosed. So we really need to strengthen that to make sure, also from AOECS as the umbrella organization, that we are maybe find other avenues to support patients. How could the national societies improve the relation with the doctors so that newly diagnosed patients to be redirected towards the association in order to receive the support they need? Yeah, this is also, I don't know if, is it clear the question, but I have seen that in some countries, the doctors immediately direct the newly diagnosed patient to the doctors. So I guess the question is how to strengthen that relationship in countries where it's not the case.
Sure. In Georgia, we do have very good association of parents who founded this association, and they are very much helpful for everyone, of course, but also very helpful for the newly diagnosed moms. I would speak from the pediatric point of view, of course, and they just help with everything: what the child should eat, how child must behave, what is the next step, what is the worst in the celiac, what is the easiest part in celiac. So the parents, the end associations should be there for when the celiac diagnosis is made. And personally, I also always suggest to meet, to speak with parents who already do have experience.
Your connection got lost, so we didn't get the last part of your sentence, Marian.
The last part, I was saying that
And
I
now,
always do you hear me? Can you hear me?
now, yes.
I was saying that I always say to the newly diagnosed patients to contact the association, and they will help in many things, and sometimes much better than we doctors do, because parent is parent, so they need also the help not from doctors, they need the help from the experienced parents also, and association, of course.
Okay, I think we can. There are still some more questions, but it seems that they will continue it. So I think we can slowly go to an end. I wanted to give a floor, like a final wrap up from each of you, if you wish, like what will be the final advice or the final comment, or what was the question that you thought, okay, this is something that I would like to explore further. Any comment from you, Marian, Jana?
Jana, should I
Jana?
start?
Yes, I'm now looking at a lot of questions and a lot of worries about celiacs not having a social life or celiacs not being able to live normally. I would just like a final thought. What I always like to mention is celiac is a serious lifelong disease, but it's also not something that should stop us from living full lives. And some of those issues can become overbearing, and we may think that it's not something that you can live with. But I think all of the issues now here mentioned are something that can be solved with a lot of work, a lot of effort. It's something that will be solved, and it can be lived with. And with the right sort of information, and with getting the support from associations in terms of information, connections, their advice, I think this is something that's very that absolutely can be lived with, and it's not something that is unbearable or unlivable. So yeah.
That's a fantastic message. What about you, Marian?
To wrap up what we discussed, first, I would thank your organization and all societies and all organizations who are fighting for rights of patients. The main thing should be much knowledge about disease, much sharing between patients, between doctors, and between patient and doctor. And we have to have structured plans, as we already discussed. And to make the structured plan, actually, it is not a big deal if we will have wish. First of all, we have to write the structure plan for patient and plan for doctors, and then it will be much easier for the both side, I would say.
Thank you. Thank you so much, both of you, because you have ended with a hopeful message. And I think that is important to say that, of course, there are problems, but here we are all to share knowledge and to support each other. For those that don't know AOECS, we are the non-for-profit umbrella association of national celiac societies, also healthcare organizations and other non-for-profit organizations that work together to improve the life of people affected by celiac disease, dermatitis herpetiformis, and other gluten-related conditions. So we are very passionate to support celiac patients, because we know that today, a gluten-free diet is the only treatment for celiac disease and needs to be done in a rigorous, lifelong way. And we invite you already to join us for the next webinar next week, same time, same day, and keep you posted about all the activities that we are doing precisely during this month of May to raise awareness on celiac disease. We want to make sure that people is aware of who we are, what do we do, and why it's important to support us. Thank you again, Jana, Marian. It was a great pleasure.
Thank you
And
so
see
much.
you in the next. Maybe you are as an audience as well.
Thank you. Thank you
Thank you
so
for
much.
inviting us, and thanks for attending.
Thank you.